that younger Black women are being diagnosed with breast cancer. And breast cancer mortality is highest among Black women. So while overall Black women sort of less likely to be diagnosed when you look at overall, but we see this mortality is higher among Black women. So in Virginia, again, looking at the incidence, we see that over 7,000 new cases of breast cancer were expected in Virginia. Over 1,000 women are expected to die from breast cancer in this year. And then the survival differences across the stage. And so what that means is, you know, whether it's early or late stage, we still see these differences when we look at Black and white women in terms of mortality. In fact, the rate for Black women is 42% higher in our state to die from breast cancer. Part of this, we think, is because of the type of breast cancer that Black women are more likely to be diagnosed with. And I'll talk a little bit about that. It's a more aggressive type of cancer, but still overall, we're seeing this higher mortality for Black women. So we look at our catchment area. And so our Facts and Faith family, you probably have heard Dr. Wynn and others talk about our catchment area, our service area, which includes 66 localities across Virginia. We see that these areas, and that's the area that's in gray, there's certain things about our catchment when we look at breast cancer. So we see that 75% of those cases in our catchment were actually treated at Massey. We also kind of look at our catchment to say, where do we see a higher incidence, or where do we think that we may have some higher mortality from breast cancer? So Richmond County, when we looked at our data, has the highest breast cancer sort of incidence, right? And then we see it's driven in part by this high incidence of breast cancer among Black women, right? Higher than we would expect, higher than the overall state. We see that some areas such as Martinsville, Petersburg, are what's called sort of hot spots for breast cancer. And then in Virginia Beach, it's been noted nationally as a hot spot for the disparity. So when we talk about the Black-white disparity. So many things happening around our state when we think about sort of breast cancer in the areas where we're serving and where our parishioners are coming from. So just when we think about breast cancer, when I say it's not just Black and white, so it's not just this racial construct that we talk about, but we know that social determinants, you know, these where you live, access to care, these long-term exposures that may start when you're born and may not show up until you're an adult matter. So these are just some papers here, but what was interesting to me when we think about sort of Virginia, that's the symbolic birthplace of African America, that individuals born during the Jim Crow time period and were young during that time are more likely to have this estrogen receptor negative breast cancer. So that's that type of breast cancer that currently doesn't have well-known therapeutic targets, right? So just living in these southern states, there's something to having a worse prognosis, right? And so now we're at a point where I think people are appreciating these type of data, where before there was this sort of distinctive sort of line in the sand between, well, what's biology that we know and the social factors. And these social determinants are important when we think about breast cancer mortality. So we think about some of the risk factors here. And, you know, for women is being a woman, right? So can't quite change that. Getting older, haven't found a way to change that. In fact, seems like every time I turn around, it's my birthday. I'm happy for it, but it does seem to come faster. So can't change being a woman, can't change age. Those are driving risk factors, having estrogen in terms of breast cancer. Then there are other things like family history. So having a family member or a sister, in fact, with breast cancer increases one's risk of being diagnosed with breast cancer. There are genetic changes, and so changes in the breast cancer 1 or 2 gene that accounts for hereditary breast cancer. A small proportion of folks, maybe about 10% of individuals, may have this hereditary component. So family history is different than the genetic component, right? Then there may be some exposures that people have had. You know, when you when you have children, if you have children or not, that makes a difference. So that reproductive history, you know, we can't really change, again, our age. biologically being a female, but we do have some control over some other things. We have control over alcohol consumption that should be limited. We have control over smoking. We have control over our weight. So there are things that we sort of can't control, but there are some things we can do that have been shown to reduce the risk of breast cancer. In terms of how do we find out about breast cancer, it's key is mammography. And so in Virginia, only about 73% of women 45 years and older are up to date with their mammograms. So, you'll find sometimes people that I've had a mammogram, but are you keeping with your schedule, right? And in terms of looking at your age, knowing your family history, knowing your risk for breast cancer, and then working with your physician to be sure that you stay on schedule for that. And this slide just thinks about in terms of, or it really shows that when breast cancer is found by mammograms, the cure rate is really high. Of 1,000 women, if they were to get screened, only 5 are going to be diagnosed with breast cancer. So with some women may be fearful of, finding out about breast cancer, but what we know is finding it earlier, the treatments are better, and it makes a difference. But most women are not going to get a diagnosis of breast cancer from having a mammogram. So we talk about sort of stage and when it's diagnosed. And so a mammogram allows us to detect breast cancer earlier. So in that sort of early stage of breast cancer. And so the one on my left, just showing sort of when the breast cancer stage 1, very localized, slightly bigger at stage 2. By the time you're getting to stage 3 and 4, you see that it's spread beyond the breast into lymph nodes. In terms of knowing breast, there are not national recommendations for breast self-exam because you couldn't do the perfect study, but we know knowing your breast tissue, what's normal for you is important. And there are some times where the mammography did not pick up breast cancer. So we need to know what's your normal so you can know your breast and make sure that you're communicating. And these are just some of the signs that there may be problems, lumps in your breast, discharge, changes in how it feels. And so it's important to be in contact with your physician. So when we talked about earlier, this idea of looking at survival, we see that, early stage, the survival rate at 5 years is close to 100%. So this, knowing your breast, getting screened is really important because it makes a difference in the survival rate. When we look at African-American women compared to white women, within each stage, we see differences by race. So we see this overall difference in mortality, and we do see differences within each stage when we compare Black and white women. That's why we need to continue to have research to understand how do we mitigate some of these disparities. We know breast cancer is not just one disease. And so one of the things that I really caution people to is it's important to have stories and to know people who've survived, but we have to be careful when we compare their treatment to what may be recommended for you or your family member, because there are many types of breast cancer. And sometimes people may not be telling you all that they had. I've had people say, well, I'm not going to do chemotherapy because of this. Somebody didn't need it, but they may have had a different type of breast cancer. And so we sort of can nowadays characterize breast cancer according to the molecular status, according to the characteristics of the tumor. And that's helping to inform the type of treatment that we have. So at the bottom of this chart is triple negative breast cancer. And we saw that highlighted on the other slide. And so people often use that terminology, more aggressive. We don't have targeted therapies necessarily now, but these are tumors that don't have estrogen or progesterone receptors, right? And so basically, when you have ER positive, like above with luminal A, then there are certain treatments that can target the growth of estrogen, right? And so with triple negative, those options aren't there. It's not as precise. And so when we think about different types of breast cancer, so there's breast cancers that are ER positive, PR positive, HER2 negative, then you may have hormonal therapy to block those ER/PR receptors to prevent cancer growth. If you look at, again, comparing that with triple negative, you may have chemotherapy, and we know chemotherapy isn't targeted, it impacts the entire body. So as we think about something like triple negative breast cancer, I think the point I really want to make here is it's not Black and white. And even when we look among women with triple negative breast cancer, we see difference in survival by age, and we see some different patterns by race. So the cases illustrated here, they're all African-American women with triple negative breast cancer. You see the 32-year-old person that was diagnosed while pregnant, had delay in therapy, decided to have her child, have the baby. We see the woman that was in her 50s, ended up having a recurrence, had severe side effects from chemotherapy, and even some toxicity for radiation that interrupted the delivery of care. The woman that was 30 didn't want neoadjuvant treatment. So she actually needed chemo before her surgery. So there was some months of delay there. And then we see the other woman at 53, triple negative breast cancer. And these are all considered sort of younger women. So these common treatments that I was just talking about, so there's breast conserving surgery, there's mastectomy that most people sort of know about. Chemotherapy could happen before surgery. Sometimes after surgery, people will hear their physicians say, I got all the cancer, you're good. And so they're wondering, why do I need anything else? Right. And so actually, it's almost now more preventive in nature in the sense that, there's cancer cells that we can't see. And so we know that chemotherapy has led to improvement in outcomes. Radiation therapy, and so radiation is often given when people have breast conserving surgery. And then there's adjuvant endocrine therapy. So the endocrine therapies are those that are targeting for women that are ER positive. So women that have that estrogen receptor positive. And what we know is unequal treatment contributes to poor outcomes. So when I was little, there was a cigarette ad actually, and you've come a long way, baby. I used to like, they had really nice clothes on it. Hated cigarettes, but I like that ad. And so we have really come a long way when it comes to our treatments that are available. And so now we are looking at treatments where we can keep the healthy cells healthy and just focus in on those cancer cells. And that's a big difference in terms of being able to tolerate therapy and some of the side effects. And so the graph to the right just really shows that we've gone away from surgery being our sort of primary way of treatment to now really having, being able to conserve the breast. Certain reconstruction has gotten much better. And now in this era of genomics, using genomic information to treat the tumor, which is quite a difference and improvement in what we were able to do. And then it's no longer a white woman's disease. This is some work in the 80s where Black women that were interviewed and surveyed felt that breast cancer didn't even pertain to them. One reason why they probably didn't see themselves represented. And so this slide looks at from the 70s when we started to collect data to now seeing, okay, once we started to have better treatments, better early detection, that's when we really started to see the difference. So here, this was white women, and this is Black women. Actually here, it seemed like white women actually had higher mortality. Treatments got better, more precise, screening got better, and we started to see this disparity emerge. So it suggests that the genes have always been the genes. We know more about the genes. We know more about the genome, but your body is still the body. And so are we making sure that we're disseminating the best care that we can to all people equally? The purpose here is really just to highlight that these are some of the landmark studies that helped us to know about the use of adjuvant endocrine therapy, in terms of different types of surgeries. The TAILORx trial made a lot of news in terms of did women need chemotherapy and also adjuvant endocrine therapy, and if they didn't have positive nodes. But what the point here is, you don't see a large representation of African Americans. So these are just a snippet of some of the seminal trials that have taken place. Lots of dollars have gone into them, and we don't really see a large representation of African Americans, not even in terms of representation in the population overall. The TAILORx trial is one of the few trials where they were actually able to test some of their findings by race. So it's important that we have this representation in these trials when we're developing our therapies. Statement here from an African-American woman, she said, it's assumed that people of color will not participate in trials or adhere to the treatment. And so sometimes people They don't ask. So I think it's important to recognize that you can't judge who will participate or not. And then secondly, that once they do, then we keep in touch with them. And so these are statements here. Now, the one that really jumped out to me was a participant who was in the SOFT trial. So that prior slide had 93 Black women in the SOFT trial. And when she asked her oncologist, not here in Richmond, her oncologist said, she says, well, what are the results? And the oncologist told her, well, we're just going to wait to see who lives and who dies. So someone that had extra visits to the doctor, extra parking, showing up, 5 years in a study after treatment, that's what they're told. So that's not what we aim for or do at Massey. We have a wide portfolio of different types of studies underway. This is just an example. So we have trials that may compare having surgery for individuals, with endocrine therapy when they're low risk. We have a study in the middle with Thompson, and this is part of NCORS. This is a national study that we're bringing here that's trying to support women that are on this adjuvant endocrine therapy. So adjuvant endocrine therapy is something that women would need to take for at least 5 years, sometimes 7, sometimes 10, and sometimes there can be side effects. And then there's also this other study really comparing different types of treatments and surgery options. And what we know is with the trials, it is in addition to, it is the sort of the gold standard plus. So, when we talk about this participation with African Americans, what we found is that when asked, Black women participate in studies. We haven't even found differences by race when we've employed some of our community-centric sort of models. And so, this team approach is really important in helping us to move forward. So, as I sort of end just saying that, Black women are telling us about their cancer experience, that they want to be involved as teams. We need to know our family history. So we need our family members to talk to each other so we can be empowered. We can control and work to our level of obesity. Get screened and stay screened. It's not just one time. So sometimes you can get a script from your doctor and take 2 years because we all get busy. So just in closing, at the end of the day, we want all of our community to be like the woman that's 30, that even though she delayed her treatment, she got in, saw her son finish high school. And to the extent that we can improve our care, we'll do that. We had our inaugural Breast Cancer Disparity Summit, and I'm going to stop here. If anybody's interested in volunteering with us, you can hit the QR code or give me a call. We're always looking for coaches, and I'm happy to take any questions.
Thank you so much, Dr. Shepherd. We do have a few moments for questions. So if you want to ask a question, you can drop it in the chat or feel free to unmute yourself and ask Dr. Shepherd a question.
Dr. Shepherd, what is the reason that Richmond County has the highest in the whole United States of America?
This is 2 levels. So I can't say we know the answer. We see that, it's a small area, number one. So the numbers or the rates, the number of individuals there in the area is small. We've been doing analysis this year, and that's where we're looking at, county by county and discovered this. We're looking at the social structures there, and we're in the process of really trying to look at some of the other risk factors aren't as high. So we don't see the highest obesity there. We don't see the highest smoking there. And so our hint may be that it's something really more structural. It's definitely driven by the high rate for African-American women in that area. So, we're doing this very sort of detailed small area analysis now, having looked at the state to really dig in and understand that, and increasing our outreach there and navigation to care.
Could you talk a little bit more about dense breasts? I think that's something that, I'd be curious if there's a higher incidence of dense breasts among Black women as opposed to white women. And again, just speculating here, if that is one of the issues that makes it more difficult to detect at an earlier stage.
So there are differences by race in terms of Black women tend to have more dense breasts. And so that's one of the things that people can't quite control. It does make mammograms more difficult to detect the cancer. Right. So we think about really it's the tissue of the breast. So dense being more full or thicker, if you think about that. So people used to think dense meant size. That it doesn't mean that. It really is about the compactness of the tissue. And so tends to be more dense breasts tend to be higher in Black women, not necessarily what we see related just to BMI and weight either, right? And so, I would say we're at a point of discovery in a couple of different areas in terms of really identifying what's unique and similar across different groups, and then developing better technologies. So 20 years ago, people wouldn't have even been talking about dense breasts, right? Some of the things that we're talking about now, we could take for granted that that's always been the case, but it hasn't. And so, but it is one of the contributing factors that we're looking at, and even how we score it, right? Where you go for your mammograms matter. Not all facilities have the best trained radiologists to read them. So that some of that gets into structure, but it also gets into knowing, uniquely why you need to understand and know your breast more. So also what's normal.
Thank you. And would you say with people dense breasts that they should get an extra level of screening? And what is that? Because sometimes mammograms, a basic mammogram won't do the trick.
So some would recommend, getting the 3D mammogram. There's some studies out now, or, that's becoming the standard. We were approached to participate in a study where folks said we still don't have enough data to know that it's better, but we're kind of out the gate now doing it. I think that having that close relationship with your physician is important overall. So we need to understand what our risk factors are. I think we want to practice to try to minimize the risk, and then, getting a second opinion if you need one, and making sure you can get the care that you feel comfortable with.
Thank you so much, Dr. Shepherd.
Sounds
We're
good.
going to move to our next speaker. So our next speaker today, we have Dr. Stacey Everett, and she has quite the bio. I believe she's going to share some of it with us during her presentation, so I won't go into too much depth, but to give you a little bit of information about her. So she was 39 years old when she was diagnosed with breast cancer. And Dr. Everett, she attests that one of her major accomplishments while being treated for breast cancer was that she was able to go back to school to obtain a doctoral degree in education. She has a bachelor's in English and a master's in education from Virginia State University. And she describes that some of her accomplishments are many, that she is a wife, a mother of two, and through her journey encourages other women to remember that every cancer journey is different, but finding the right cancer team who will listen to you will help set the foundation for you to make it through. So Dr. Everett, we thank you so much for being here with us, and I'm turning it over to you.
Wow, I couldn't have said that better myself. Thank you so much. Well, thank you so much for having me, VCU, to the team, Dr. Shepherd, and Dr. Nguyen. VCU has been instrumental in so many ways, and I just appreciate you including me in your Faith Fridays as well. One of the things that I did want to emphasize about breast cancer is that breast cancer can be, I'm sorry, I can't say can be, breast cancer is life-changing. It's one of those things that, no one ever wants to hear those words, you have cancer. And what do you do when you hear them? That's always the major concern. That was my major concern. I'm sorry, okay, there I am. That was my major concern when I heard it. Actually, for me personally, I was angry. And I was angry, and I was angry because, I found a lump myself in January of 2010. And I went to the doctor, I watched it, I monitored it, I did everything they said, put the pin, see if it grows, put the little mark and watch and pay attention and do your self-exams and get to the doctor right away. Well, I thought I had done all those things. I had my first mammogram when I was 27 years old because my mother was a breast cancer survivor. And so she made sure that when I was 16 years old that we knew how to do our self-exams. And one year, VCU actually was going around communities, and they had these sample silicone breasts that you could actually feel a lump inside the silicone breast. And it was like, I had never, who knows what a lump in your breast might feel like. And when I felt that, I remember thinking to myself, wow, if I ever feel that, I know that, my doctors are just going to, all kinds of bells and whistles are going to go off, and my doctors are just going to do everything they can to save me and save my breast. Well, long story short, and going back to the first thing I was saying, that didn't happen for me. And that's what made me so angry. When I found the lump, I begged my doctor, I said, wait a minute, this isn't right. I asked my doctor for another mammogram. That didn't happen. I asked my doctor because it had been 6 months since I had my previous one, so they didn't want to do it again. I went to a doctor, he looked at me, he said, you don't have breast cancer. And he said, you're fat. No, I'm sorry. He didn't say you were fat. I heard you were fat because he said you were overweight, you're Black, and you're 40. And I said, well, wait a minute. I'm 39. I'm 5'9". I'm 174 pounds. I don't think I'm overweight at all. And, whether or not I'm Black shouldn't matter, because, I'm a bunch of things, So why did that play in your decision for you not to even do a clinical exam on me? And at that moment, I decided that, too many people are in that position where they don't want to hear you have cancer. And when a doctor tells them, don't worry about it, your breasts are just dense, then you run into an issue where you hear what you want to hear and you don't do anything about it. And I've seen too many people who have fallen to the wayside, who have passed on because they heard the word, oh, don't worry about it, your breasts are just dense. And because people are underinsured, because people don't have the right insurance, because people don't have the pedigree, for lack of a better word, to determine whether or not you deserve the best care. There are a lot of people who have passed on. One of the things that concerned me most was that there was a concern with my insurance company. My insurance company said, my doctor said I needed an MRI. They called the insurance company. Insurance company said, you need a diagnosis. Well, my doctor said he can't make a diagnosis without the MRI. And my insurance company said they can't give me an MRI without a diagnosis. So when I offered to pay for it myself, all of a sudden, there was another reason why. So needless to say, and long story short, I'm sorry, I feel like I'm babbling a little bit. Long story short, I found a lump in January 2010, and I was not diagnosed until May of 2011. By this time, when I compare my reports, the tumor that I had grown 3 centimeters, and I was in stage 2B aggressive. Because initially, when they did do the MRI, my doctors found that there were, they thought they saw cancer in both of my breasts. So they recommended that I have bilateral mastectomies. And at the time, because I could feel the lump growing, I totally agreed. And I felt that it wasn't necessary. It wasn't necessary for me to try to fight it, to try and say, you know what, I want to keep my breast. I'm going to do everything I can to save it. It's really great to hear Dr. Shepherd say now that there are some things that, people that we're doing more to conserve the breast. But at the time, I really didn't, there was no other option for me, knowing my history, knowing that, my mom had breast cancer, knowing that it had grown so quickly. to where it was from where it was to where it currently was. It turned into a no question. What's the word I'm looking for? It was no question for me. It was just, one of the things that I decided right away. I said, well, you know what? If you're recommending that I have the bilateral mastectomies, I'm going to go ahead and do this. When can we make the surgery? So, and right away, I started treatment. They wanted to shrink it first. So I started my treatment. And when I once I had my treatment, they were able to shrink it enough. They were able to stop the growth. And when we had the surgery, I went right into reconstruction. It's all happened at the same time. So I did, I came out of it feeling much better, considering the fact that I realized that I didn't have cancer anymore. But there was always that concern in the back of my mind. Now every time I get a headache, oh my goodness, is it cancer? Every time that, something doesn't feel right, is it cancer? And that's something I'm not sure, maybe I need treatment or something, but I need therapy. But do we, how many people find themselves in that situation where they don't know what to do? And there's always that thing in the back of their mind. And more than that, are we going to get the treatment that we actually need and deserve? One of the things that concerns me was, with the treatments that are out there now, they weren't out there before. I'm seeing so many things, and I see that, when I first got involved, I honestly felt that, what happened to me should never happen to another person. And if I have anything to say about it, I'm going to make sure that what happened to me doesn't happen to another person. You're not going to, marginalize me because of my complexion, because of my height, because of my size, because of my age. No one should ever get a diagnosis of, hey, just stop eating fatty foods. The fried chicken is out. No one should just, don't smoke cigarettes anymore. No more Pepsis and coffee for you. No one should have, that should not have been my treatment. But that was what the doctor recommended for me. And the funny thing about it was, I didn't eat a whole lot of fatty foods. We baked and broiled everything, boiled, didn't eat a lot of fat at all. I never smoked a cigarette in my life. And as far as, what was the other? And as far as caffeine was concerned, I might have had a cup of coffee once a month, and I didn't drink Pepsi. So, then those were the things that I was told. So, it was a horrible situation in that fact. But how many other Black women had to go through that, and that's what concerned me then. Programs that we have, like the Sisters Network, the BC, the Virginia Breast Cancer Foundation, even in Petersburg, we have a program called Pink Challengers. When we talk about those programs and we get an opportunity to talk with women, we get an opportunity to hear the stories, to compare stories, to share stories. When we hear those things and we're able to encourage one another, that is one of the things that makes all the difference for everyone, for each person. And I think that in recent years, localities have taken responsibility for the women in their locales. Now, during COVID, it was striking to see the number of people who decided not to, get their mammograms because they couldn't get out, or the doctor's offices, they couldn't see them, and I honestly feel like, I'm not sure what the statistics are, but I can imagine that the numbers dropped, tremendously for the people who were actually going out to get their mammograms. And I know it hurt my community probably more than any other community in this area. I live near Petersburg, because, if you're already marginalized and now these other things are going on, that's more of the reason why you still have people that are sitting at home and not getting their mammograms. So I wanted just to say that, I appreciate what with VCU, with MCV, what Massey is doing in getting us out to the communities, to creating the Champions program, the breast health research advocates, to get out there into the community, equipping these people, training these people so that they can know what to say and know what to do so that you don't have a me again. You know, you don't have, no one actually has to experience what I went through, because you have the coaches who are available, you know, and they're out there and they're doing what they can in our communities. You know, we have so many things that we can be doing, and we have so many things that we are doing, and there are so many things that I can envision that we're going to do. You know, it started for me with the Breast Health Summit that VCU had over the summer. You know, for me, that was such a step in the right direction, watching the community champions become a part of the research, you know, become a part of, you know, what's out there, and actually dealing with, the cutting edge of the research that is going to forward cancer research in the future. So when we think about those things, things are happening. Now, how do we encourage the people to get more involved? We have to continue to stay in their ear. We have to continue to get our faith-based organizations involved and say, you know what, hey, are you doing your mammograms? Have you been to the doctor? Are you doing your self-exams? You know, are you eating right? You know, what is your diet? You know, getting those other programs involved, you know, like the co-ops and and the universities involved in making sure that we're doing everything that we can to make sure that we're caring for the women. You know, and I'm saying just women, but I know that there are men who have breast cancer as well. You know, so when we talk about our breast health, you know, what are we going to do in these small communities to address the fact that we, more white women still get breast cancer, but more Black women are dying from it, you know, and that's still a fact today. So how do we keep those things from happening? And it's things like this that are going to make the difference. So I'm going to stop right here. I know that breast cancer is life-changing. I know that, you know, people who are underinsured, people who don't have the right type of coverage, you know, they aren't getting the care that they need. And we have to get to a place where we can start to treat the disease. You know, we have to start to treat the disease, and not just the disease of cancer, but, you know, the disease of racism, the disease of marginalizing people, the disease of separation, the disease of disunity. You know, when we can all come together and we recognize that this is not just something that is, you know, oh, if all the Black women are dying from it, then it's okay. No, we're affecting our entire society. So it's up to us to really make the difference. And I would encourage anyone to do what you can to encourage the next person that you know to ensure that you're doing everything to take care of not just yourself, but your body, your neighbors, your friends. Get those exams, get those mammograms, do your self-exams, and take good care of yourselves. Thank you very much.
Thank you so much, Dr. Everett. And just so you know, there are some words of gratitude to you in the chat, so check those out. I know one of the questions I wanted to ask, you mentioned some of the groups. You said the Sisters Network, and you mentioned Pink Challengers. Can you talk a little bit about that, and that those are opportunities maybe that we can share with other individuals?
Well, Sisters Network, that is through through VCU that we get together, and we actually work and develop as coaches to help other women that are going through to actually walk them through the entire process, to advocate for them, to help them in making sure that they ask the right questions and they do the right things to further their care in the best way, you know, and also and I think it takes the fear out of it, just knowing that you have that support. Pink Challengers, I know, was started about 10 years ago, and we worked with the breast health research champions, and that was before, I'm sorry, SIS, I said Sisters Network, it's SIS, Sisters and Former Sisters, not Sisters Network. Thank you, Yvonne. But the Pink Challenges was in Petersburg, and we were meeting at the YMCA. Right now, we're doing everything online. But if, we're always open to bringing more people in. And like I said, most of the people who were in the Pink Challengers became part of the breast health research group. And, we still meet and encourage each other and help each other through our processes. It's just a support group that's out of Petersburg. Sisters and Former Sisters.
Yes,
Not the
thank you
Sisters
for
Network.
clarifying
Sisters
that.
Network. Yeah, Sisters Network is a little bit different. Yeah.
Yeah, so Dr. Everett was referring to Sisters Informing Sisters. At the end of Dr. Shepherd's presentation, she showed a slide of that study that's to help Black women as they're going through treatment for their breast cancer. The QR code that was dropped in the chat is specifically for that study. So if anyone's interested in learning more about that, they can. Does anyone have any more questions for Dr. Everett? I see some questions in the chat about breast cancer and insurance in general that I'm sure Dr. Shepherd can help us address before we sign off.
You just made a statement concerning only for Black women or for women in general, the program you mentioned.
Yes, Reverend Bibb. So the program is it's a research study that's funded by the American Cancer Society. And it's an intervention that was specifically made for Black women that are going through breast cancer. So there's a document in the chat that if individuals are interested in learning more about that, you can scan that and it'll tell you all about it. But if Black women that are diagnosed with breast cancer, they can, if they agree to be a part of the study, they can get randomized to a usual treatment path, or they will get a coach that will go along with them through the path. And this is to test this intervention that Dr. Shepherd has developed over the years. So that study is specifically for Black women.
And we can drop in this chat, I think Yvonne can maybe drop the Engage Massey. And so that's a way that we are working to really train community members about cancer, so that they can work just within their social networks, and just have a little more information. Because one of the things I think is important, that when someone is diagnosed and comes to us, that we can point them to reliable sources of information. One of the things that I have seen, sadly, is that people have said, well, I'm not going to have chemo because my mom said if I have it, then that's not God's will. I've experienced that myself, so some of the work that we do has been motivated by misinformation of people that I've lost, that they're not here anymore, because by the time they decide to have their treatment, it has spread to their brain. So we want to have as much information as we can. And if we don't have the knowledge to know, where do we go to places that we trust? Because you can find anything you want on, and we know it, on the internet. And just because it's in an infographic, it doesn't mean that it's real information. So Engage Massey, if we put that in the chat, Yvonne, then people can reach out, whether they want to volunteer, just learn more. I am going through answering some of the questions too that we have here. And I know this is being recorded to make sure people get the answers.
Yeah, and Dr. Shepherd, one thing I wanted to add, I'm sorry, one of the things that I lost my train of thought when I was talking was, one of the problems that I did see, I wasn't recommended to go into a clinical trial. I didn't find out much about it until after my treatment was over. But one of the things that does concern me is that, that one article that my doctor was using to say that, I was, overweight, I was Black, and I was 40, that was actually an article that was in a research that he was studying about Black women, and what I found is, as much as I dug into the research to find out more about what the research was saying about me, I couldn't find much. And the reason why I couldn't find much is because there aren't enough Black women taking part in the research. So how do we get rid of it? How do we make the research look like us? We have to have people who do look like us involved in the research. I know there's a lot of fear about it, but the only way that we're going to be able to address it is if we get involved. And I would encourage anyone to get involved in the research and to engage Massey, get the clinical trial information out there, find out exactly what people can do to involve themselves in the research. And I think that would help us in forwarding and in dealing with the disparity in cancer research.
Thank you so much, Dr. Everett. That was a good way to summarize everything. And it's also, I think, important as we talk about this, and we're talking about Massey, that we highlight, that Massey Cancer Center is a national cancer, NCI designated cancer center. And we are fortunate to have an NCI designated cancer center here. And we want to educate about it and encourage individuals to try to get treatment if they can at NCI designated cancer centers because of the type of resources, the wealth of knowledge, the access to clinical trials that the NCI designated cancer centers have. And we recognize that some people in the community may not be able to have access to it, but we're thankful that we have Massey here. And our goal is to provide care and outreach and education, not just to those in Richmond, but in our catchment, which spans a fair majority of our state. So I want to thank Dr. Shepherd and Dr. Everett for joining us today. Thank you so much for educating us and teaching us about breast cancer, getting us started and revved up to do some work and advocate during Breast Cancer Awareness Month. I want to give you a couple of points or announcements before we leave. And so you may have already received an email about our next Facts and Faith session, which will be in October, and we will have Dr. Gary Gibbons with us, who's the director of the National Heart, Lung, and Blood Institute at NIH, and he will discuss cardiovascular disease and what we can do to help our patients, families, community members, and congregants around that disease. We also have the Virginia Breast Cancer Foundation. They're sponsoring a breast cancer awareness luncheon. That is on October 3rd, and this will be at the Hotel Roanoke Conference Center. And then we have next month, Aaron Steigletter of the Virginia Breast Cancer Foundation and Dr. Jessica Young Brown from VCU will be joining us during our closed session for clergy and leaders. That's October the 7th. And Dr. Brown will continue the theme of the toll of the pandemic on the mental health of clergy. So we ask all pastors, faith leaders, associate ministers, et cetera, to please join us for that session. Now, at the beginning of this, it was completely on me, and I apologize that I did not see Dr. Patricia Gould-Champ on, but she is still on, and she stayed with us, and I very much so appreciate that. So if you would not mind, Dr. Gould-Champ, would you please close us out with a word of prayer?
Let us pray together just for the fact that you always are mindful of us and everything that we stand in need of. And so even today, God, we thank you for providing these two awesome speakers, but really those who have come and have ministered to us through information and sharing their own personal testimonies. And as always, God, we know that you are indeed a healer, and we know that your healing also involves providing us with the information that we need so that we can manage our self-care. And so now, Lord, as we leave from this meeting, we thank you for the information. We thank you for the inspiration. We thank you for the encouragement. And even as we go forth, may your word be true for all of us, that we would be well and be in good health. Bless all of those, Dr. Todd, and all of those who have been responsible for drawing us together. And as always, God, we thank you for your divine presence. Bless us as we go and keep us well. In the name of Jesus, we pray. Amen.
Thank you all, and I hope you all have a great weekend. I hope to see you next month at our next event.